Hello, good afternoon. Naririnig na po. Okay, so we're already in our week 9 of, of our lectures in NCM 118, and our topic for today is your stroke. So I know some of you are already familiar with this one. So the stroke, this is a medical condition in which there is poor blood flow in to a part of the brain, no, that causes cell death. And your building blocks of your brain is, diba, your neurons, going back to your anatomy and physiology. And as you all know, neurons, it does not regenerate. No? So, meaning pag namatay na or nasira na yung neurons nyo, and that is permanent. No? It will not regenerate anymore. You will not form new neurons, no? Unlike the other cells of your body wherein, diba, may magbibuild ng bago or ano. So, when it comes to stroke, that is the reason why yung stroke nagkakause siya ng disability, because the neurons na dating nagpe-perform, no, to do some of your motor and sensory functions is now destroyed due to the poor blood flow to a certain part of your brain. So when we talk about stroke, syempre we're talking about blood flow. We will be talking about the different arteries, no, that um is covering, no, yung ating brain, or the one that supplies blood to our brain. So these arteries meaning they carry, no, they carry oxygenated blood, no, to your brain tissues. This is what we call your circle of Willis. So ito po yung tinatawag natin circle of Willis. So if we will be checking, this is your circle of Willis, this is your brain, and these are the different arteries. And for us to easily remember yung mga arteries na yan, is we have to divide the brain, no, into the anterior and the posterior. So this is your anterior portion, and the other half is your posterior portion. So next, since there is napakadaming mga arteries dyan, no, and we have to name some, so we will be naming the most important, no, ng mga arteries in your brain. So we have already divided the brain into the anterior and posterior part. So let's go to the different arteries that provide circulation to the anterior part of your brain, and that is your ACA. You have the ACA, your MCA, and your ICA. And the posterior part of your brain naman, you have the PCA, the basilar artery, and your vertebral artery. So later on, malalaman natin kung what is the significance of knowing the anatomy and physiology of the brain and the different functions, no, of the different areas of your brain. So let's go first, now to the anterior part. So the first artery that provides circulation to the anterior part of your brain, there's a major artery here, is your anterior cerebral artery. So this is your anterior cerebral artery right here. And this is your anterior cerebral artery. So if you look at the anatomical location, it is the one that provides, no, circulation to this particular area of your brain. Yan, yung median area of your anterior brain. And this median area of your brain, no, somehow ang function yan is to provide sensory and motor function of your lower extremities. Now next is this right here. So this artery right here, this is also known as your medial cerebral artery. So if you look at the anatomical position of your medial cerebral artery, somehow it provides the circulation on this area until this area, yeah, this area of your brain. And going back to your anatomy and physiology, so this area of your brain, itong part na to, has something to do with the sensory and motor function of your upper extremities and your face. Next is this right here. Yeah, so this artery right here, so this is known as your internal carotid artery. So kaya siya internal, if you look at its location, it is internal. The location is internal. So if you will look at the anatomical position of your internal carotid artery, it somehow it branches out to your middle cerebral and your anterior cerebral artery. So that we have already covered the three major artery that provide circulation to the anterior part of your brain. Now let's go to the posterior part. So first, and this part is this artery right here. This is your posterior cerebral artery. So it somehow provides circulation from this area right here. Ayan, and then dito din. Next is your basilar artery, which is found right here. This is your basilar artery right here. Ayan. So this provides circulation from this area right here. Ayan. And if you will go back the anatomy physiology of your brain, so around right here, you will find the pons. So somehow your basilar artery provides circulation to your pons. Also some area of your cerebellum rather, right here yan. And last is your vertebral artery. This is your vertebral artery right here. And somehow your vertebral artery provides circulation to this area right here, part of your cerebellum, and itong area na to, which is your medulla oblongata. And as we remember, in anatomy and physiology natin, the basilar artery, or the pons rather, has something to do with the communication and the pain sensors. Also, the cerebellum naman has something to do with balance and coordination. Your medulla oblongata, something to do with swallowing, digestion, and breathing. And also your cerebellum. Also nga, cerebellum, balance and coordination. So now we have identified the three major arteries that supply blood to your anterior part of your brain, ACA, your MCA, and ICA. In the posterior part, you have the PCA, your basilar artery, and your vertebral artery. So now let's go to the etiology and pathophysiology of your stroke. I know some of you are already familiar with this one, but for stroke, we have a condition we call your transient ischemic attack. So what's the difference between your transient ischemic attack and your ischemic stroke? First, when it comes to the manifestations, it will be neurodeficits. So almost the same, as silang dalawa. The manifestations is the same. There will be neurodeficits to your patients. And the only difference between the two is in the transient ischemic attack, this is caused, there will be no infarctions. So when you look at the brain imaging results of the patient, there will be no infarctions. And the symptoms of the patient usually lasts less than 24 hours. As for your acute ischemic stroke, same lang. It is presented with neurodeficits. But now, if you look at the brain imaging results of the patient, there will be infarction. And usually, the symptoms of the patient will last more than 24 hours. So as for the cause of your transient ischemic attack and acute ischemic stroke, we have different causes, etiologies. First is the hypoxic cause. So the hypoxic cause, from its name hypoxic, so there is lesser oxygen going to the brain, and some conditions that can cause this, either your patients had cardiac arrest, tumigil yung heart, which is the one that pumps blood going to your vital organs. Next is your patients having shock. You're already familiar with shock and its different subtypes. Also, if your patients have respiratory failure, wherein the heart or the lungs is failing to do its function to provide oxygen to the blood supply. And next cause natin is your embolic causes. So from its name, embolic, is caused by an embolus that was that's impeding the circulation to the brain. So the main cause, or the most common cause of an embolic stroke, is your cardioembolic in nature. So since cardioembolic, meaning the embolus came from the heart and was pumped going to the brain, kaya siya cardioembolic. And bakit siya yung pinaka most common cause? Because of the proximity of your heart to your brain, di ba? And merong big vessels na nagsusupply dyan, which is your carotid arteries. Also, the risk can be increased if your patients have atrial fibrillation. Because we already know, ng atrial fibrillation, yung patient ninyo hindi na empty effectively yung kanilang atrium due to the atrium. The atrial muscles are just fibrillating, and it may cause the increase the chance of a clot or a thrombus is being developed in the atrium, and it may be pumped to the brain. Also, if your patients have left ventricular aneurysm or your valvular diseases, we have already established that in valvular diseases, your patients have abnormality in the atrioventricular or your semilunar valves. Either it is constantly open or may prolapse, no, and it will allow entry of a thrombus, no, or an embolus, may and it may be pumped, no, to the brain of your patient. Also, we have a paradoxical embolus right here. So the concept behind paradoxical embolus, it can be seen in patients with patent foramen ovale. So what happens is, for example, you have your patients had DVT, may thrombus na naging embolus, and was distributed, no, to the heart of the patient. And since your patient have a patent foramen ovale, so what happens is the thrombus, no, may travel, no, from the right side of the heart through the patent foramen ovale and may go to the left side of the heart to be pumped, no, to the brain. So that is your paradoxical embolus. Next in our cause is your thrombotic cause. So the main culprit in the thrombotic causes of stroke is your atherosclerosis. It can happen in small vessels and large vessels. And as we already know, no, during your NCMB 312, no, you have already, it was already mentioned during your coronary artery diseases, no, that the risk factor for atherosclerosis, either we have the non-modifiable, which is the age more than or equal 60 years old. Also, the male gender is more prone, no, to development of your atherosclerotic plaque. Also, if your patients may modifiable causes naman is your hypertension, if your patients have diabetes mellitus, no, smoking, obesity, and hyperlipidemia. So that is the most common, no. So what happens, no, in this risk, no, so what happens, for example, yung patient mo is aging, also, no, the blood vessels lose their integrity, no, as we age, no, and with the losing with it losing its integrity, the more chances na magkaroon tayo ng what we call an atherosclerotic plaque. So this is made up of lipids, enclosed in a fibrin membrane. And sometimes, if your patients have increase in the blood pressure, so sometimes it may damage, the fibrin cover of this, due to the increase in the pressure. And remember, these are lipids, so your platelets, would love to attach itself with these lipids, forming what we call a thrombus. And sometimes this thrombus, syempre, as it grows over time, it will cause, for a complete or a partial blockage of blood flow going to the brain, causing either an acute ischemic stroke or a transient ischemic attack in the process, depending on how large is the blockage. And next natin is your hemorrhagic type of strokes. So for hemorrhagic type of strokes, we have two major causes or types. You have your intracerebral and your subarachnoid. So they differ, depending on the area wherein the hemorrhage is starting. So kung intracerebral, meaning it is within the brain parenchyma. And when we're talking about subarachnoid hemorrhage, it is within the subarachnoid space within the brain. So what are the causes of your intracerebral hemorrhage? So it can be caused by your hypertension uncontrolled. So kung remember, your brain or your central villus, meron siyang maliliit na blood vessels, and sometimes pag uncontrolled ang blood pressure ng patient, it may rupture some of the small vessels in the brain, causing an intracranial hemorrhage. Also, if your patient has cerebral amyloid angiopathy, meaning there is yung mga blood vessels nila in the brain is much more brittle. Also, if your patients have coagulopathy, and if your patients have hemorrhagic transformation. So for hemorrhagic transformation, usually this happens, as a result of the medication that we give for stroke. For example, your patients had acute ischemic stroke and they are a candidate for the medication or the drug. So we give them the TPA, and sometimes one of the adverse effect of your TPA is your patients will have intracranial hemorrhage. Also malignancy. So the malignant cancer cells, may may be transferred, to the brain, as metastasis, and it may damage some of the blood vessels in your brain, causing intracranial hemorrhage. Also trauma to the head, It may cause your intracerebral hemorrhage. For subarachnoid hemorrhage naman natin, it may be caused by cerebral aneurysms, or if your patients have arteriovenous malformations, and also trauma to the brain. So we have already established the different etiology and pathophysiology of your stroke. We have identified transient ischemic attack versus your acute ischemic stroke, the different causes, and the different risk factors. Now let's go to the clinical manifestation. So the clinical features of your patient, first, it is depending on which area of the brain has an impeding circulation. First is your ACA. Sabi natin kanina, kung ang ACA has something to do, it provides circulation to the median part of your anterior brain, and the median part has something to do with the lower extremities. So the reason why, so makikita mo kung ACA yung affected will be on the lower extremities. Kung sensory and motor, so what you will see is contralateral weakness of the lower extremity. Motor, diba? Motor weakness. Also, you will see sensory loss of the contralateral side. So, bakit nga ba contralateral side? Kasi going back now into your brain, for example, this is your spinal cord, no? Oh, wait lang. Sumatawag. Opo. Sige. Sige. Send mo na lang sa akin. Chat mo na lang sa akin. Patay yung Gcash number. Okay, so going back now, this is your, for example, this is spinal cord. So going back to our anatomy and physiology, for example, you have a pain stimulus here, in your hand. This is a stimulus. So going back to the signals, now the signal of the pain stimulus will be sent to the left side, So left side to, ito right side, to left side. The left side of your spinal cord, and then the signal will go to your brain. And then once na nandito siya sa brain, it will be transferred on the contralateral side. So depending kung upper extremity yan, saan siya pupunta in this part, diba? Yun yung sabi natin upper extremity. That is the reason why also with the motor, so kung dahil pain stimulus yan, kailangan niya alisin yung kamay niya, the motor signal will also be sent subsequently from the contralateral side going to the limb. So kaya yun aalisin niya yung kamay niya. That is the reason why yung clinical features ng patient ninyo with stroke is on the contralateral side, because the sending of signals is going to the contralateral side. So also, aside from the contralateral weakness and sensory loss, your patients will also have abulia. So your abulia is a decrease in motivation. What you will see, or what patients will be presenting with, is a delayed in their response. So there will be a delayed response. So for example, pina-thumbs up nyo sila, sobrang tagal bago nila gawin. Also, they will be having akinetic mutism, and that is the absence of movement in some patients. May pinapagawa kayo sa kanila and they will not respond, Next is your MCA syndrome. So your MCA naman, sabi natin, it supplies blood to yung different parts, and it has something to do with the upper extremity and the face movement and sensory function. So kung affected ang MCA, what you will see is a contralateral weakness and sensory loss, more on the upper extremities and the face than your lower extremities. And also, since affected ang sensory, you will also see contralateral hemanopia, so meaning mawawalan po ng vision yung contralateral side, and it will cause the patient to more nung titingin sila more on the ipsilateral side or the affected side. Aside from that, in the MCA, you will also find there in your area na supplied by MCA, you will also find there the Broca's area, and the Wernicke's Wernicke's area. And yung okay, so yung ating Broca's and your Wernicke's area, no, it has something to do with your speaking. So yung Broca's area has something to do with expressive speech. Your Wernicke's naman has something to do with receptive speech. So what if affected yan, what you will see in your patients is they will be having expressive aphasia, meaning alam nilang naiintindihan nila lahat but they cannot express no yung gusto nilang sabihin. That's the reason why hindi sila nakakapagsalita. While on the Wernicke's aphasia naman, it will cause receptive aphasia, meaning kaya nila magsalita ng words but they cannot understand or comprehend what is happening around them. Kaya meron silang receptive aphasia. If you add the two, that is what we call your global aphasia. Next, in your right dominant hemisphere naman na MCA, pag affected, what you will see is apraxia and neglect. Neglect in terms na they will be neglecting one side of their body. No? So, kahit anong inflict mo ng pain or maglagay ka ng mainit, no, hindi nila papansinin yun, and that is neglect. Next, if ICA naman po ang affected, what you will see in your patients is they will be having ACA and MCA syndrome, since your ICA natin branches out to your MCA and ACA. So you will see a combination of both symptoms. So pag syndrome, di ba, collective of symptoms. Next, let's go to your posterior. Kung PCA naman ang affected, what you will see is contralateral homonymous hemanopia in our patients. Also, they will be presenting with alexia without agraphia. Yung alexia without agraphia is your patients cannot talk, no? But if binigyan mo sila ng pen and paper, they can write, no, yung gusto nilang sabihin. Also, they will be presenting with contralateral hemibody pain and your midbrain syndromes. Kung affected naman natin is basilar artery, no, sabi natin it provides circulation, no, to your pons. So what you will see in your patients, no, pag medial pons yung affected is there will be ipsilateral nerve palsy, cranial nerve number 6 palsy. So that is your abducens, and your abducens has something to do with lateral eye movement, no. So yung patient mo, since ipsilateral, they cannot gaze, no, hindi sila makatingin, no, laterally to the area that is affected with stroke. Also, they will be presented with contralateral weakness and sensory loss. Kung lateral pons naman yung affected, what you will see is they will be having an ipsilateral cranial nerve number 5 and 7 palsy. So that is trigeminal nerve and facial nerve. So going back to your anatomy and physiology, trigeminal nerve has something to do with your facial sensation, no? While your facial nerve naman has something to do with facial movement and mastication. So mahihirapan din mag-chew on the affected side. Also, may drooping, no, on the affected side. Next, since affected din ang sensory, there will be deafness to your patient. And since affected ang kanilang hearing, no, your patients may have vertigo, no, and vomiting and nystagmus. And sabi nga natin, affected yung facial nerve ng patient mo, so they may be having drooping of eyelids. We call that acertosis. And since it is also providing circulation to the cerebellum, affected ang coordination and balance ng patient. So your patients may have ataxia or unstable gait. Your dysmetria or abnormal coordination. So yan po yung, di ba, isang test na ginagawa natin sa neurologic assessment is the finger toes test or the heel shin test, no. But in this manner, they cannot do, no, proper coordination skills. Also, this diadokinesis. So in this diadokinesis naman is your patients will be presenting with abnormal alternating movements. For example, they want them to do close open of their hands, so they'll be having a hard time doing that alternating movements. Next is kung vertebral artery naman yung affected natin. So sabi natin it provides no circulation to your medulla, no. So in your medulla, you will see there, no, your cranial nerve number 12. So your patients will be presenting with ipsilateral cranial 12, a nerve palsy or hypoglossal that has something to do with the movement of the tongue, right? and your patients will be presented with contralateral weakness and sensory loss. Also in their medulla, since kung lateral medulla ang affected, your patients will have dysphagia or difficulty in swallowing, dysarthria or difficulty in articulating their speech, kaya may slurring of speech, uveal deviation, and ipsilateral facial and sensation loss. Affected din ang kanilang cerebellum, so they'll be presenting with ataxia, dysmetria, and dysdiadokinesis as well. So now we have already established that depending on the different areas of the brain. Now let's go to your hemorrhagic types of stroke. So we have two major types again, your ICH and SAH. So both are presented. So this is what differentiates your hemorrhagic stroke from your acute ischemic stroke. In your hemorrhagic strokes, they will be presenting with headache. And the difference lang between the two is in your subarachnoid hemorrhage, it is much more severe type of headache. No, we call that as your thunderclap headache. No, usually your patients will describe it as the worst headache they had. No, for the rest of their lives. And also, both will be presenting with increased intracranial pressure signs because remember, your brain is a compact, no, not tissues, and any bleeding in that area, no, may cause an increase in the pressure inside that. And your increased intracranial pressure signs, no, you will see altered level of consciousness, nausea and vomiting, Cushing's triad. No, you like your hypertension, bradycardia, and irregular respirations. And also, what differs your ICH from your SAH is in your subarachnoid hemorrhage, your patients will manifest meningeal or meningitis signs like your Kernigs and your nuchal rigidity. So now we have already identified the different clinical manifestations of your patients with stroke depending on the regions na affected. No, hindi na to yung alam niyo na generalized lang, no, na body weakness. No, it's meron po tayong iba't iba. And also with knowing the different regions, we will also know what will be the point of care natin. So now let's go to the diagnosis of your stroke and your treatment. So for the diagnosis and treatment of stroke, the American Stroke Association provided us with the 8 Ds of stroke care. So that is for us to easily remember how to diagnose and manage our strokes. So the first D in the 8 Ds of stroke care is your detection, also known as the early detection or early recognition of stroke symptoms. No? And you're already familiar with this as the fast mnemonic. So yung fast mnemonic na yan, it has a name. Itong fast mnemonic, actually, it is named the Cincinnati Pre-Hospital Acute Stroke Scale. No, so, ginagamit yan. Kaya siya pre-hospital, it is being taught to the general public. And it is tinuturo natin yan sa kanila to know or for them to recognize stroke symptoms as early. And with your Cincinnati Pre-Hospital Acute Stroke Scale, so ito po yung ginagamit natin mnemonic, which is your FAST. F stands for facial asymmetry. Ang tinuturo natin dyan, or if you want to check for that, you ask the patient to smile and you check for symmetry of the facial features. Next is arm drift. Dito naman, we ask the patient to close their eyes and raise their arms forward and try to maintain that position for 10 seconds, and you check if there is dripping or drifting of arms down. And next is learning of speech. Dito naman, we ask the patient to repeat the sentence and we check for the articulation of the speech. And for the time, we always instruct them to remember when was the patient seen well, or what we call the ictus or the symptom of onset, because it has something to do with the time frame of the different modalities in treating the stroke. Next D is your dispatch, or also known as your rapid EMS dispatch. So here in the Philippines, we already have a unified emergency number, and that is your 911. This is implemented September 11, 2024. So pag meron po tayo mga emergencies, we may call 911. That's also the reason why if you go to your barangays, meron dyan mga patient patient transport service, and so on and so forth. And that is part of the implementation of the unified emergency system na meron tayo, para mapapabilis yung mga services. So pag tumawag kayo ng 911, since that is unified, to ano yung kailangan ninyo, ilalapit sa inyo ng 911 or the unified emergency number. Next D is your delivery. and that is the quick transport of the patient via EMS, no, to a hospital. So remember here, hospital, no, capable of treating stroke. So when we're talking about capability of treating stroke, they should have the following. They should have a CT scan, so they will be able to differentiate kung ano bang type of stroke yung nangyayari sa patient. They should also have the medication intended to treat the stroke, which is your TPA. They should also have an operating room, no, if ever na yung patient ay hindi candidate, no, for the TPA. And if they should have an acute stroke unit and an ICU. And when we're talking about ICU and ASU, we're talking about the skills of the nurse as well. They should also have a neurologist, a neurosurgeon, no, in the vicinity, no, dun sa hospital na yun. Next D in the stroke care is your door, also known as your effective triage and your room assignment. So, if ang hospital na pinagdalhan mo is a stroke-capable facility, so they will be having this brain attack protocols. So itong brain attack protocols, like for example, sa St. Luke's, pagka nag-activate kayo ng brain attack protocol, so there is a simultaneous chain of events that will happen. So, simultaneous meaning sabay-sabay mangyayari yan. Upon activation, so dito tinuturo yan sa lahat ng empleyado ng hospital, no? And anyone can activate the brain attack protocol, no? So kunyari merong kahit ng guard, housekeeper, marunong yan, and alam nila yung tatawagan. So once for example nag-activate the brain attack protocol sa hospital, this is hospital wide, simultaneously first what will happen is there will be a brain attack team that will go, no, to the site of the incident kung saan may na-stroke. Pupunta ang brain attack team doon. The brain attack team is composed of neurologist, a neurosurgeon, stroke nurse, no, and a social service or a liaison officer. Pupunta sila doon sa area. Next, after that, simultaneously, the CT scan department will be reserving, no, one machine for that patient. Also simultaneously happening is the emergency room will be reserving a bed, no, intended for that patient. And also simultaneously happening is the stroke unit or the ICU, no, will be clearing one bed, no, intended for that patient depending on the severity of the stroke of the patient. And also simultaneously happening is the billing department and the admitting department will also be preparing, no, the needs of the patient if ever, and prompting na yung relatives, no, on how gaano kalaki yung mga gastos nila, and that is happening simultaneously, no, pag nag-activate ng brain attack protocol. So kung ang hospital ninyo ay walang ganyan, so most likely that is not a stroke center, no. Almost all, lahat ng stroke capable hospitals meron pong brain attack protocol. So kung wala, that is hindi po. So hindi po sila a preferred area na pagdadalhan ng patient with stroke. So next, also in the door is the room assignment. So it should be an acute stroke unit or intensive care unit. And when we're talking about acute stroke unit or an intensive care unit, we're talking about the skills of the nurse, not only the bed itself, no. So one part is the equipment, but the other part is the skills of the nurse, no. And sabi nga natin, yung stroke nurse na yan is a specialization. So kung gusto nyo maging nurse kayo in the future and you want to have a specialization, that is one, which is your stroke. No, yung malaki rin ang binabayad sa mga stroke nurses, lalo na ngayon na mataas ang incidence natin ng stroke, no. Not only here in the Philippines but globally, no, mataas ang demand when it comes to stroke nurses. Number 5, no, in your D is your data. That is the collection of data and medical history. So here, ang mga tinatanda natin, syempre first is the ictus. So that is the time of onset of the neurological symptoms appear. And the risk factors, we have already established this, no, the age, male, hypertensive, diabetic, may hyperlipidemia, no, obesity, and smoking. And syempre in the data, we have to recognize, no, na stroke po talaga yung that your patients have neural deficits. Ino, shh, turn down the sound. Ino. So for this, what we use is not po yung Glasgow Coma Scale. I know some of you iniisip, when it comes to stroke, it's Glasgow Coma Scale. No. Hindi po ginagamit ang Glasgow Coma Scale in recognition of stroke. It is only being used, no, for assessment if our patients are deteriorating. No, but instead of using that, what we use, no, in recognizing signs and symptoms of stroke is your NIH stroke scale. So yung NI stroke scale, I will be uploading this in your G drive, no, along with the pre-hospital acute stroke scale. So, ito po yung ginagamit natin to recognize na talagang stroke yung case ng patient. So, yung NI stroke scale, may iba't ibang tests doon na ginagawa, and it is scored from 0 to 42. No, and this is just a summary on yung mga tinetest doon. The patient will be tested when it comes to the level of their consciousness, their best gaze, no, yung kanilang eye movement, and the visual fields, no, they will be testing the different visual fields and the visual integrity, also the facial palsy, yung asymmetry and movement of the facial features, also for motor function, the strength and coordination of upper and lower extremities and even the face, also the sensory function, and also the language, the ability to speak and understand language, diba? Aphasia, Broca's aphasia and Wernicke's aphasia, and also dysarthria, no, yung the clarity of speech or articulation, and the extinction, no, which is the neglect of one side of the body. So, kung meron na establish yung patient mo, you will be grading them according this system. 0, pag 0 nakuha, there is no stroke symptoms. Pag 1 to that is minor stroke. Pag 5 to 15, that is moderate type of stroke. And pag 16 to 20, that is moderate to severe. And 21 to 42, that is severe type of stroke. So, when it comes to interpretation, the higher the score of your patient, no, the poorer the prognosis. Pag poor ang prognosis, meaning mas malaki yung chance na magkaroon ng disability ang patient mo, mas mataas yung chance na mas magiging mahaba yung rehabilitation process, no, and mas magiging aggressive yung treatment, so on and so forth. So also, if we have already established also part of your data, no, next na test na gagawin natin is the gold standard, that is your CT scan, no. So a non-contrast CT scan will be ordered, and this is only intended, no, to differentiate if yung case ng patient mo is an acute ischemic stroke or is an hemorrhagic stroke. So what you will see, no, in the brain imaging of your patients is there will be kung yan ay acute ischemic stroke, is there will be hyperdensities, no, in the different regions of the brain na maliliit. So that would signify, no, na merong mga fresh blood clots, no, or an embolus, no, in the circle of Willis of the patient. While kung malalaking hyperdensities naman na makikita mo, kung within the brain parenchyma, that is your intracranial hemorrhage, no. Kung within the subarachnoid hemorrhage naman, kung within the subarachnoid space, yung bleeding or yung hyperdensity. Kung medyo late naman na, or for example, recurrence of stroke na, yung testing, what you will see is hypodensities or medyo darkened yung area of the brain that is already affected by stroke. This is a late sign na. Kung lalo na kung matagal na, no, kunyari 2 days ago pa yung stroke, tapos ngayon lang na pa CT scan, so usually hypodensities na yung makikita mo. Aside from that, no, since we know, no, na kung nasang area, no, or that is an acute ischemic, if you wanted to know particularly what artery is blocked, and now we can do your CT angiogram. No, and this is how we find the occlusion. So yung CT angiogram, although hindi siya ginagamit, no, early, no, usually in the late signs na yan, or the late period na ginagawa ang CT angiogram, and this is to find where is the exact location of the occlusion. Next is we can also do other tests. You know, we can do your CBC, you can do your basal metabolic panel, you know, your coagulation studies, PT, PTT, INR, troponins, so the ECG to the echo, and also your point of care glucose. This is to know the etiology of the stroke. No, malaman natin kung ano ba yung nag-cause ng stroke, or sometimes ano ba yung condition ng patient that is nag-cause ng stroke. So since we have already established this one, na alam na natin yung sa patient, now let's go to the next D, no, in your stroke care, and that is already in the treatment, and that is your decision, no, and this is the time that you will choose, no, between the ano ba yung treatment modality na gagawin natin sa patient, and that is either a drug or a surgical intervention or other measures na. So with this, number 7 natin is drug. For acute ischemic stroke, we only have one drug, no, na ginagamit natin for your patients, and that is your TPA, also known as your tissue plasminogen activator, no. So what it does, no, is it increases the plasmin, no, in your blood. And remember, your plasmin, no, somewhat breaks down fibrin. So for example, this is your blood clot, no, and it is enclosed, no, by fibrin. So if you will increase your plasmin due to this drug, no, somehow this plasmin, no, destroys fibrin. And once the fibrin is already destroyed, no, by the plasmin, this will, no, dissolve na, or mawawala na rin yung clot. So that is the function of your TPA. But and this is the only medication that we can give to your patients with stroke. Just the tips to remember, no, when we will be giving your TPA, no, should the ictus should be within 3 ictus. So this is the window period wherein you can give your TPA. So the ictus, or the onset of symptoms within 3 to 4.5 hour window. There should be neuro deficits, kaya po sabi ko hindi po GCS ang ginagamit natin, kasi sa GCS it will be eye opening, di ba? Verbal and your movement, or your ano lang, muscle movement, no. But for neuro deficits, kailangan talaga pasok siya sa neuro deficits. So ang ginagamit natin to establish that is the NIHSS. Also, there should be no contraindications. So the absolute contraindication for TPA is if patients have bleeding tendencies, no. So kung meron, hindi po sila candidate. Ano ba yung mga bleeding tendencies mo? If your patient is, yun nga, abnormally na meron siyang ano ngayon, may menstruation siya, or may hemorrhoids, or may gastrointestinal bleeding, or your patients are taking anticoagulants or antiplatelet medications, if your patients have uncontrolled super high blood pressure, diabetes mellitus, no, so they are not a candidate for your TPA. So if ever naman na maging candidate for TPA yung patient mo, so one of the responsibilities of the nurse is to compute for the dose. So tayo po yung magbibigay ng medication, and in computing the dose of your TPA, ito po yung ating ginagawa. That is 0.9 milligrams multiplied by the weight in kilos ng patient. So, and we have a threshold dose which is 90 milligrams. Meaning, for example, yung patient mo is 120 kilograms, no? Times it by 0.9, you will give you 108 milligrams, right? But since we have a threshold, no, which is 90 milligrams pa rin yung ibibigay mo. Not unless mas mababa, no? That's the time na yun ang susundin mong dose. Now, that na-compute mo na yung max dose ng patient mo, for example, for this equation is 90. The next thing is you will get the 90% of the 90, and that is you will be giving it via bolus. And the remaining 10% you will give it via infusion, no, for 1 hour. So that is how you give your TPA. And once your patient is already, nabigyan mo na siya ng TPA, remember, they are prone to bleeding. So anong gagawin natin? Siyempre, there should be no blood test or any na injury na i-inflict sa patient, no. Bawal silang lagyan ng swero, bawal sila, kasi it may cause bleeding to the patient. So next, if your patients are not candidate for this drug, sabi nga natin, this is the only gold standard medication. The other medications na nakikita ninyo na binibigay sa stroke patients is not actually to treat the stroke, but just to decrease the risk of them having another stroke, no? So kung hindi sila eligible, no, that will also prompt us to the next D, which is your disposition, no? So you will do other disposition in managing the stroke of your patient. So in your disposition, pwede tayong mag-undergo ng thrombectomy. So in your thrombectomy, it has a longer time period, that is 6 to 24 hours from symptom onset, and it is good for clot in the big vessel. So kailangan mo muna mag-angiogram to know where exactly is the location. So in your thrombectomy, for example, meron ka ditong for example, you have here a blood vessel, no, with a clot, no. So what you do in your thrombectomy is you will insert the catheter, no, and then after inserting a catheter, you will inflate a balloon, no, in the catheter, and then after inflating, may ipapasok ka dyan na parang stent or a wire mesh, no, also coming from this catheter, and then you will scrape down the thrombus. That is your thrombectomy. But it is good for big vessels. Kung mga small vessels, hindi na po yan kaya pusukin ng catheter. Next is your carotid revascularization. Usually we do this in your carotid stenosis if your patients have carotid stenosis. So for example, this is the carotid artery of your patient, may atherosclerotic plaque. No, same lang, you will insert a catheter, no, and then afterwards you will place a stent, no, here. So yung stent ay para siyang wire mesh. Yan, and then after you will leave it there. No, so that's your carotid artery stenting. So that will help no the carotid arteries to open. And then once na meron ka na nakalagay na carotid na stent dyan, no, since wire mesh to, it will also prevent no embolus no from entering to the brain circulation. Next is kung ang patient mo naman is a transient ischemic attack or a mild type of stroke, no. So what our goal is to prevent no the recurrence of stroke. And with that, we can do your risk stratification. So ito po yung mga nakikita ninyo mga gamot. In risk stratification, what we do is the ABCD2 risk stratification. So it's based on the yung mga modifiable no, risk factors ng patient. So what you do is we put this one, ito yung ginagawa natin. We check for the age of the patient. Kung yan ay more than 60 years old plus 1. Kung ang BP niya ay more than or equal to 140/90, another plus 1. Kung ang clinical features ng patient mo is aphasia during the transient ischemic attack, plus 1. Kung aphasia plus weakness, that is plus 2. Kung ang duration naman ng symptoms niya ay less than 60 minutes lang, that is plus 1. Kung more than 60 minutes, that is plus 2. And kung diabetic yung patient mo, that is another plus 1. And then you add mo lang yung risk niya. Kung less than 3 or equal to 3, that is low risk. Kung 4 to 5, that is moderate risk. And from 6 to 7, that is high risk. No? So what now? Kung alam na natin yung risk ng patient mo. So kung alam na natin yung risk ng ating patient, what we will do next is we will decrease the risk. No? So in decreasing the risk, kung ang patient ninyo ay ito yung mga pwede mong gawin. Kung hypertensive, you may give an anti-hypertensive. Kung ang patient mo naman is diabetic, you may give your insulin and anti-diabetic medications. Kung hyperlipidemic naman, you may give statins. Kung may smoking, no, you may smoking cessation, obesity, you may ask them to lose weight, no, or help them to lose weight. No, anti-platelet medications like your aspirin, clopidogrels, kung meron silang mga sakit sa puso, yan. If your patients are pwede rin magbigay tayo ng anticoagulants like your warfarin, your Dowax, no, like your Apixaban or the Bigatran. So yan po yung mga binibigay natin sa ating mga patients no may stroke. So next naman natin is our disposition if ang patient mo naman ay merong hemorrhagic type of stroke. So, kung hemorrhagic naman ang type of stroke ng patient, usually the hemorrhagic type of stroke no, is caused by coagulation issues. No? So, kung coagulation ng issues ng patient na ang problem natin, you may do the reverse coagulopathy. No? Lalo na kung hemorrhagic transformation no, yung naging cause. So, what you can do is we reverse the coagulopathy no, by giving your antidotes. Kung warfarin ang cause, you may give your vitamin K. Kung heparin, protamine sulfate. For DOAC, no, your prothrombin complex concentrate. Kung TPA yung nag-cause, you may give your tranexamic acid and your cryoprecipitate. Next is for hypertension. Syempre, we have to maintain no, the blood pressure of the patient, and that is not to exacerbate the bleeding in the brain. And with that, we may target the BP systolic of your patient around 140 to 160. So, hindi po pwedeng mas mababa or back to normal. Why? Because that is a compensatory mechanism of your body to increase the blood flow to the brain. Kaya tinataasan niyo yung pressure. So, kung babagsak yan, babagsak din ang perfusion to the brain. So, what we can do is we target 140 to 160. And in targeting, no, ang best choice natin is your IV titration medications like your nicardipine, labetalol, or hydralazine. Also, kung ang patient mo naman ay medyo marami yung bleeding, for example, ito yung brain, yan. So, kung medyo marami yung bleeding no, in the part of the brain, so you may do craniectomy. So, to decrease no, the intracranial pressure, you may do craniectomy. So, pwede tayo mag-ano ng hole no, in the head of the patient, and that will be to release no some of the intracranial pressure. Yan. So mag kayo ng hole. So that is your craniectomy. And if possible or kaya, you may do an open brain surgery and to manually evacuate no the blood clots in the brain. Also in ICP management, no, you may also do mannitol. So yung mannitol ang mechanism in your mannitol is kung nasa blood vessel mo or nasa circulobillus mo yung mannitol. So pag naglagay ka ng mannitol or 3% saline, so it will pull no some of the fluids no from the bleeding part para bumaba yung intracranial pressure going to the blood vessels. So next is in your subarachnoid hemorrhage. For example, kung ang problem naman natin is within the subarachnoid space lang, no, for example, nandiyan yung bleeding. So what you can do is you can coil the aneurysm. No, you may coil the aneurysm or surgically clip the aneurysm to stop the bleeding. So that is for your subarachnoid hemorrhage, but it will be done in an open brain surgery. No? Also, since may bleeding, you will also manage no the blood pressure of the patient. Same lang. Systolic BP 140 to 160. Syempre, since may target tayo, IV titration yung preferred natin, like nicardipine, labetalol, or hydralazine. And you may also give your intracranial vasodilators. So these vasodilators like your nimodipine no, will help to decrease the pressure also in the brain. Since magiging vasodilated yung blood vessels, mas magiging maraming blood no yung makaka-penetrate dun sa blood vessels, and it will help no in the reduction of the intracranial pressure of your patient. So that sums up no our topic for strokes. So before we end, do you have any questions or clarifications? Any questions or clarifications from the group? Any questions or clarifications po? Do you have questions, clarifications? If you don't have any questions or clarifications, no, so next week you will be having your quiz. Yung quiz po ninyo is on hypertensive emergencies, your shock, and your stroke. So, kung wala na pong questions, it's already 4:08 and you are dismissed early. Thank you.